Kostas Stamatopoulos. I'm a hematologist and currently the director of the Institute of Applied Biosciences in Thessaloniki, Greece. Today, we will be discussing the current state of CLL treatment and the unmet needs. CLL is the most common form of leukemia in the Western world, representing between 22 and 30% of all leukemia cases worldwide, though the proportion of cases may be lower in certain Asian countries. Patients are usually diagnosed with CLL later in life, with a median age of 72 years old at the time of diagnosis. In a study of 373 patients with CLL identified from a Mayo Clinic CLL database, 89% presented with at least one comorbid health problem. With this in mind, treatment for CLL is rarely curative and may require long-term treatment, meaning that tolerability is an important consideration when selecting treatments. The presence of patient comorbidities has an impact on treatment tolerance and definitely influences the choice of therapy. In a prospective cohort study that followed 1,143 patients diagnosed with CLL over a 3-year period, 40% of patients had hypertension and 27% had a cardiac condition at baseline. Furthermore, the presence of multiple comorbidities may impact treatment outcomes in patients with CLL. Indicatively, a retrospective study following more than 550 newly diagnosed patients with CLL revealed that patients with 2 or more comorbidities had decreased progression-free survival compared with those who had 1 or no comorbidities. For patients with organ dysfunction and/or poor performance status, tolerability to therapies is a key consideration. CLL is a disease that can rarely be cured, and therefore, the primary goals of treatment include effective and durable disease control, symptom management, and ensuring treatment tolerability. The treatment goal for individual patients will depend, at least in part, on their physical fitness. Starting with chemoimmunotherapy, it does have a proven efficacy in CLL, but the goal of durable remissions may not be an option for patients who are less fit. Patients who are older or less fit are prone to more chemotherapy-associated cytopenias, with increased risk of infections that can negatively impact survival. In such cases, it may be more sensible to focus on improving the symptoms of CLL, which reduce quality of life and minimize therapeutic toxicity. A variety of therapies may be used to treat CLL in the first-line treatment setting, many of which are administered as combinations. Continuous therapies, including BTK inhibitors and PI3K inhibitors, are administered until disease progression, unless there is unacceptable toxicity, with finite duration therapies, including BCL2 inhibitors, monoclonal antibodies, purine analogs, and alkylating agents, are administered for a predetermined number of treatment cycles. The choice of therapeutic regimen may depend on individual patient characteristics, such as a patient's preferences, the presence of comorbidities, performance status, age, and other prognostic markers. Now, since numerous treatment choices are available, patient priorities are becoming increasingly important when selecting a CLL treatment. Patients with CLL prefer to have treatments that are efficacious but are also tolerable. Indeed, in a patient preference survey on first-line CLL, 220 patients were presented with hypothetical treatment profiles with varying attribute levels. Patients placed the highest relative importance on longer progression-free survival. The risk of adverse events was also important. A significant additional improvement in progression-free survival was required to offset the inconvenience of worsening adverse events. In summary, CLL is a chronic condition that may require long-term treatment, meaning that tolerability should be a key consideration when selecting therapies. The primary goals of CLL treatments are effective and durable disease control, symptom management, and treatment tolerability. When choosing a therapeutic regimen, this decision may depend on individual patient characteristics, such as a patient's preferences, the presence of comorbidities, performance status, age, and key biological prognostic markers, such as TP53 gene disruption. Furthermore, the identification and careful monitoring of adverse events after initiation of treatment and supportive care for treatment-related complications should be an integral part of CLL management. Thank you very much for your time and attention today.